So on to our last session before our lunch break. We have a truly distinguished speaker, Professor Jesus Villar, who's from the Canary Islands. He's been kind enough to come from the tropical paradise that is the Canary Islands to join us here in rainy Atlanta. But nonetheless, he's really truly one of the international experts, both in ARDS, he's been working in that field for many, many years, but also in lung protective ventilation and the different settings for the ventilator for the best way to manage patients. So I'm really looking forward to hearing him talk. He's also been one of those truly international figures. Obviously, he's been very active in Spain, has been elected in the College of Medicine there and been distinguished in a lot of the research that he's done, but also has worked in Toronto. He actually worked in Macon, Georgia as a professor for a while too, right? And so he's a very international person who's really worked in different areas, has a very good sense of what goes on around the world. So he's going to speak to us today about lung protective ventilation in 2017. Where are we now? So Jesus, please come and
Got it. Thank you. Good morning. I speak Spanglish, so yes, you're right. So Bruce, you know that. So if you have any problem in the question session and the question part of my lecture at the end, so you just ask me what you didn't understand from my talk, and I will be pleased with the help of Greg Martin to answer. You know, we are happy today, not specifically today, but this year, because we celebrate the 50th anniversary of the first description of ARDS. It was published in the British journal, Lancet, in 1967 by 4 physicians from Denver. The paper, the curious history about this paper was rejected from the New England Journal of Medicine and JAMA and some other American journals, end up in a British journal. That is one of the most quoted papers in critical care medicine that ever has been published. So 5th anniversary. So I like to go with you today to travel, to do a journey of 50 years, but I can't because it takes me hours and hours talking here. But I want to compress those 50 years in 27 years, and I want to compress the last 27 years in 45 minutes. Nobody? So you have to realize that in order to compress that, the vast and incomplete information that we have until now, you know, I have to summarize a lot of things, but I think this is something that you will need and you will really appreciate, because I have filtered a lot of junk publication and junk knowledge and old knowledge, but I would like to leave at the end with a person, you, that is different when you came in and you are going to when you go for lunch, okay? I would like, my goal is that at least you will get 3 to 4 new messages that will change the way you practice. Or if you practice according to what I said, to confirm that what you are doing is fine. And it's so far until 2017 is correct. So let me first to declare my conflict of interest. I have a grant from a ventilator company, Macon. It's only for research. I don't receive money from them, only to pay the research that still we are doing. Nothing of where we are going to or I am going to speak is related to this company. This 27 years old journey started in 1990. Okay, forget about what happened before. In 1990, guys from New Zealand, Hicklin is the first author and the leader of this group, they published in Intensive Care Medicine an interesting paper. They published their experience with and how they ventilate patients with ARDS. Well, something else. During my whole talk, I'm going to talk about the ARDS, but people use different definition. Papers use different definition. I am not going into these details, but I will tell you that the definition in that paper was not the definition that we use later, because American Consensus Conference definition was published in 1994, and the Berlin definition was published in 2012. So this was according to acute lung injury, a score, wasn't a score. Anyway, they published the experience of ventilating patients in New Zealand in their unit by limiting the peak airway pressure, by using tidal volumes as low as 5 ml per kilo. Remember, in those years, the Bible said, the formula said, the book said that you had to ventilate between 10 and 15 ml per kilo. So 5 ml per kilo, that was revolutionary. And to use the PEEP level, adequate to maintain FiO2 if it's possible, less than 0.6. And do not care too much about PCO2, because with asthma patients, you don't care too much, so why we had to make a difference? So they published, and what is important about this paper, not only because of the tidal volume, is because the mortality rate, this is 50 consecutive patients in the ICU. Mortality rate was 16%. This is the lowest ever has been reported. So that was too good to be true anyway, because it was not a randomized controlled trial of anything, just was a report of their own experience. So they only compare with the mortality rate that is predicted by the severity of this patient. And the prediction said that the expected mortality rate was 40%. So this is why they conclude that ventilating patient this way is better than traditional way. So this is how the whole movement of lung protective ventilation started, because they knew that a lot of knowledge already in animal experiments support that mechanical ventilation, that the ventilator can kill you. The mechanical ventilator can kill you. If the mechanical ventilation is not applied according to physiology. We knew already the high pressures and high tidal volumes at high rates can damage the lung. Not only can damage the lung, can perpetuate the damage that is already done or is already there, and can propagate the damage that is in the lung to the systemic circulation by producing the release from the lung of mediators that cause inflammation to other organs. That was one of the explanations, is still an explanation, a hypothesis. The reason why many patients, or most of the patients who die from ARDS, died from multiple system organ failure. In fact, today, very few people die from ARDS. They can die with ARDS, but not from ARDS. Interesting, right? So that was the basis to set in 1994, 1995, to perform a randomized controlled trial in the United States, funded by NIH, what is called today the ARDS net work, okay? And they published the study in the year 2000 with almost 900 patients, admitted in multiple sites, comparing, in the year 2000 in the New England Journal of Medicine, comparing two strategies. One, the traditional ones that were used in the United States and in other parts of the world. And with the other one, that the difference between one and the other was the tidal volume in one group was 6 ml per kilo, a number that was very low for any standard, compared to a double. They didn't say 6 versus 9 or versus 10, like we, in those years we use in Europe, but they decide 6 versus double, 12. This is one of the things important in this study. The other thing is, for the first time, that a new concept was introduced. That instead of not only the 6, that people became confused about the number 6. And I'm going to clarify this very soon. Because this is one of the first message I'm going to give you is in the next slide. They calculate tidal volume based not on your body weight, but on your predicted or ideal body weight. So suddenly, I realized that Dr. Martin, Greg Martin here, has the same lung size independent of his weight. So because, imagine that tomorrow he's in a movie and they ask him to increase weight, muscle, he will work very strongly because I know he likes to be a movie star. And he will weigh maybe 20 more kilos. His lung are the same size. But if you calculate the weight, eventually with 20 more kilos, you will give a higher, a 20% higher tidal volume. Imagine that you are in the philosophy in the year 2000 that you provide 12 to 15 ml per kilo. You end up giving 20 ml per kilo to Professor Greg Martin. So you will kill him. He will never have a chance to be an actor. And this is what happened in the past. We did a lot of iatrogenic mechanical ventilation. Of course, was not intentionally, because all the experts in the world, the leaders, it was the chance to see and listen and shake hands with all these experts in the world, that they told us that this is the way to ventilate patients. So, this is the first study showing that at least the difference between 39% versus 40% is 9% of death is related to the ventilator. Because not everyone with 6 ml per kilo survived, and not everyone with 12 ml per kilo died. Okay? But at least this 9%, that is a lot, is responsible in mechanical ventilation. Now, the first message I want you to remember forever. It doesn't matter if we are rats, cows, bears, dogs, cats, whales, a bat. All mammals in this planet has the same tidal volume. All mammals, I repeat, in this planet have the same tidal volume. And the tidal volume is something that already has been explored, examined, validated, confirmed by zoologists in the late 50s and early 60s. We forgot. And those who don't remember the past are condemned to repeat it, as you know that. But we didn't have emails. We didn't have internet in those years. We didn't have, to get a journal or a book with this information. Maybe you never get it, or it takes years. So we end up in the year 2004 to collect that information and expose to everyone in order to understand why the number 6. Because this is, if we go to a pulmonologist, a respirologist for a pulmonary function test, they will tell us that our tidal volume is between 5 and 7 ml per kilo. In fact, in the ARDS net study, they didn't apply exactly 6. That was the average. It was between 4 and 8. Okay? The median was 6. The mean value was 6. So now you remember this. This is not an opinion. This is a fact. This is not a religion. It's not that I don't believe or I believe. This is a fact. Our tidal volume in a healthy, normal lung is 6.3 ml per kilo. Of course, predicted body weight. For animals, they don't have predicted. They have the weight they have. But for us, we have for the same height, different weights. So it should be the weight, predicted or ideal body weight. So if that is true, why we don't do it? Because people, if I now ask you, I don't know to ask you, how many people use tidal volume of 6? Everybody will raise their hands. You are big liars. We are big liars. I always raise my hands too. Okay? Because if you go to the clinical records, like some people have done it, you discover that very few people, in fact, the people who does it, very few times, they follow this fact. Because it's not an opinion, okay? That we don't do what we say we do. That is going to change very soon. Believe me. Yesterday night I have a dinner. I was invited for dinner. They pay. No, they pay for the dinner. And we talk about how it's going to be the medicine in the future, or critical care medicine in the future. It's going to change very fast. Very fast. And in one of the things that are going to change is because of the legal issues. Because this information will be known by everyone. And they will say, hey, doctor, or nurse, or auntie, my father is being ventilated. I make a calculation, and it looks like it's 9.5 ml per kilo. And I read on internet that the tidal volume, a guy from Spain, Dr. Villar, published that it was 6.3 ml per kilo. So I would like to know why you decide to be different. Somebody asked before about a dosage of anesthesia, and you say 5 milligrams, whatever. Of course, we have a dose for everything. We cannot give any dose that we want. We had to give a dose that is provided, has an effect. So soon, this is going to be a legal issue. It happened in the United States, the same thing, with this. It's a nice story. Nice story. It's about the gastric ulcer, When two Australian guys discovered the ulcer was produced by an infection, people around the world were laughing. They said, these guys are crazy. An infection? This is a chronic disease that you live forever with this. We treat it with no coffee, with some diazepam, with some, drinking milk. You have to avoid all this, excitement and things and that. You change your life. And then if you bleed, you go to the emergency department and they change the anatomy of your body. Because they do anastomosis here, there. They have techniques. So it was very rare that surgeons don't go every day to the operating room to save the life of a guy with gastric ulcer. Today, this is very, very unusual. Because today, you treat gastric ulcer with treatment of antibiotics for 2 weeks. Forever. Maybe 5% have to repeat it. Gastric ulcer is an infectious disease. What a revolution here. But it took 12 years, 12, I don't joking, 12 years for the gastroenterologists to be convinced that they have to give antibiotics. And they did it, could be 14 or 20 years, because the Mayo Clinic decide that if you don't do it, this is malpractice. So of course, Mayo Clinic decide to treat with antibiotics. Now, in a day, 55 centers, 1,000 centers in the United States decide to do the same thing, and then the whole world. These people got the Nobel Prize. Because this is a fantastic discovery. Okay? So it's going to be the same thing with tidal ventilation, with this low tidal, because this is what happened. Published in 2016, but the study was done in 2014. People don't follow the evidence. In fact, don't follow the fact. Because it's not because the ARDS net found that 6 is better than 12. It's because they don't believe that 6 is your total volume. Let me see if I see here. Okay. So in this study, for example, with more than 2,000 patients, it was done in a study in 1 month in 50 countries. Forget about the weakness of this study, they have many. But they found out that 40% of the patients with ARDS, 40%, in the first day, they received more than 8 ml per kilo of tidal volume. In fact, some of those patients were treated by physicians who live in the middle age, because they were applying tidal volumes up to 15 ml per kilo. These people will go to jail because it's not the patient. Important. 40%. They don't listen. But this was published the other day. This is amazing, because it's not that randomly you study for a month clinical records of patients and see how they are ventilated. No. This is randomized controlled trials that you are forced, it's mandatory to follow certain recommendations. And one of these recommendations, what happened? It's because I talk too much, I know. So what happened is, it's not that you suddenly discover that people is applying any kind of tidal volume from 4 to 15. Look at the range. But it's that in the studies that you're supposed to follow the protocol and say, hey, this group is ventilated with lung protective ventilation. The tidal volume should be between 4 and 8. They don't do it. And then it's published in the New England, in the Lancet, JAMA, this guy. The mortality is this and that. Forget it. You cannot trust in those results, because these guys found out that 3 very important randomized controlled trials, some of them funded by the NIH, big liars. They don't ventilate the way it should be ventilated. They discovered that the patient on the first day ventilated with tidal volume that is out of range of the protocol. Even for those patients in the in the lung protective ventilation arm. So it's very difficult really to trust and to believe in the results of a study that they don't show the truth. You don't think so? So I believe that in the future, results of the study should be public. Especially if not especially, I don't make any distinction. It doesn't matter what's funded with public, with the taxes, or is private funded. Because if you publish the results and you want to make a message or an application afterwards, people have the right to know the truth. And the data should be published. Should be public. Published, of course, even if the study is negative, because you don't want to repeat the mistakes of other people, but it should be public. And eventually, this is another thing that will come. Medicine, the research data should be public. Because people like to torture, this is a nice word, to torture the data until get something. So in this study, they show that 60%, not 40, 60% of the time, people were out of the protocol. So I don't trust in the results, they said. I don't trust. That's it. This is the message of this beautiful summary of this study. People don't apply what they're supposed to apply. Imagine that you compare two drugs, two doses. You say you have to give 5 milligrams and you have to give 10 milligrams. You compare 5 versus 10. But the guy who decide to, the patient who are randomized to receive 5, they receive 10 or 8 or 11. So who cares about the results? So this is the same thing. I don't know why, really. I don't know why. But I know that it's not the ventilator. It is not the ventilator. It's you. And soon, this is what is going to happen. I hate to talk about ventilator-induced lung injury. It's like the ventilator has life. It's a living creature. No, it's not a living creature. You are the living creature. You are the one who manipulates the ventilator. So it's a physician-induced lung injury. Who disagree with this? Anyone? Good. Now let's take another look to the results of the 6 versus 12 ml per kilo. So now you have the first message, tidal volume, okay? Let's go to the second message, plateau pressure. Interesting concept because Hicklin said he wants to limit pressure below a certain limit, certain number. So instead of peak pressure, plateau. Well, it was an analysis of almost 900 patients. In those patients were ventilated with 12 ml per kilo and 6 ml per kilo. And this is how it looks like, the curve. Here you have plateau on the first day, and this is the risk of death. So 10, 20, 30%. Here you have patients with a plateau pressure again, and the risk of death with the 6 ml per kilo. I told you, not everyone survived, and not everyone died in both extremes. But now, let's put this together. Because the only message that I can tell you about this comes later. So we do it together. And this is how both figures, I didn't do anything, just put it together. Looks like. And you see that this is a portion that the greater the plateau pressure is, the mortality is higher. And it's a certain range of plateau, because when you combine these two curves together, between 20-something, 23, 24, and 29, between 22 and 29, in which a mortality rate, it doesn't change. It's stay in the same range, okay? And then this portion here, I never heard that before, but I'm going to tell you. Forget about this portion. It's not that the lower, the mortality is lower. No, I don't think this patient has ARDS. Because they have a pressure that is normal. So the definition they use to include patients in the study, allowed to include patients that don't have ARDS. They have the criteria for half an hour. And half an hour later, they don't have ARDS. So in fact, they didn't have ARDS. So this is why I'm not interested in this part. It's like a dead in a six. Of course, people who is normal, they shouldn't die, So these people who has no ARDS and nothing else, intubation, and 24 hours or 48 hours later are extubated and out of the ICU, they don't have ARDS. It's impossible to cure ARDS in 24 hours. If you have a system, you just tell me, because, I will send you to the CNN that is here in the city. Remember this, 29, looks like above 29, you start dying exponentially. Interesting data. The third variable that I would like to talk, and is related to the plateau, is called the transpulmonary pressure. Remember, that I said above 29 of plateau will be the explanation for the increased mortality in that group. But in fact, independently of tidal volume, you have patients with 12 ml per kilo with a plateau pressure that is below 29. In fact, even below 25. For us today, we know by physiology that the best indicator of overdistension or ventilator-induced lung injury, let's continue with the ventilator-induced lung injury, or ventilator-associated lung injury, is transpulmonary pressure. That is easy to calculate because it's plateau minus pleural pressure, the pure physiology. Now, we cannot measure pleural pressure, but we can measure something very similar, a surrogate of that is esophageal pressure. Very soon, you will see, very soon, this is going to change, very soon. Everybody in the ICU ventilated, I would say for more than 12 hours, they will have a nasogastric tube that at the same time is a monitor for esophageal pressure. Why to have a catheter only for feeding? So you save 2 or maybe 3 functions in the future, or 4 functions, who knows? But one of them will be to measure the pressure in the thorax. So we can measure this very simple. And in fact, we already know that the transpulmonary pressure below 27 does not produce ventilator-induced lung injury. That is a safe limit. And because transpulmonary pressure is plateau minus something, you already know what is your safe limit. If you are below 29, fine. You are below 27, even better. That is something that's going to change. Those figures are going to dominate the way we ventilate patients in the future. Not just the VT. You have to add something else, but because I said, you have patients with high plateau pressure and high transpulmonary pressure in both groups. In patients ventilated with 12, that we don't ventilate, we hope we never ventilate patients with 12 anymore, and in patients ventilated with 6 ml per kilo, or even below 6. In fact, in one of the lines in the paper, in the ARDS net in the 2000, they said, we recommend, our study suggests, the implication of our study is that we should ventilate between 5 and 6, doesn't matter if you go to 8, but 5, and with the goal, with the aim to maintain a plateau pressure of 28 or less. I will say it's less than 29, 28. That's good. Let's change now. We go to the tidal volume, plateau, the one that is related, that is transpulmonary pressure. We go now to PEEP. Well, for PEEP, another revolution has came. Because for PEEP, I don't have a formula. I don't have a formula for PEEP because we're still waiting for some results this year and the next year of studies that are finishing. One is finished, one is finishing, and next year we'll finish another one. Big studies, larger studies. But the only thing I can tell you about PEEP is this study. This is a summary. It was published in 2009. In fact, the first author, Susan Phoenix, is a medical student. How many medical students are here? None? Here, one? Look, you can be famous. This study is very famous. It's a meta-analysis, systematic review. They pull all the data, all the studies, comparing 2 levels of PEEP, high and low. Forget about what is high and what is low, but higher than lower. And they combine the results, even though meta-analysis, even though here they are mixing apple and oranges and bananas, so this is, the meta-analysis is not the result of a study separated in portions. It's not a pizza with all these portions. No, it's not a pizza. Okay, it's a different kind of food because it's rice, chicken, pizza, different food because different patient, different definition, different environment, different times, different level of PEEP. But at the end, well, they have 2,500 patients divided into arms, and it looks like the random application of high level of PEEP save lives. This is something I can say, save life. So if I have to, what I mean with this is, if you have a patient with ARDS, 12 of PEEP is better than 5. We already knew that for a long time, for more than 50 years, but, you will be surprised to see that in those studies, some clinical records show that the patients were treated with PEEP of 0. If in my whole life I was able to treat a patient with ARDS of 0, I will be expelled from my ICU by my boss. That is a sin. To have an ARDS patient on PEEP 0 is a sin. It's a sin. And you will find that in many studies. I don't know what kind of education people have received to treat a patient with ARDS with less than 5 of PEEP. Even today, I can say, if Bob Kasmari was here, I would say even with less than 10 of PEEP. Because it's a sin. This is the ventilator-induced lung injury. This is the physician-induced lung injury. It's not the ventilator. We try to prove the ventilator, but it's you. Now, the question is, okay, high PEEP is good, but how high? How much? Well, it's not a recipe. Because we are now entering in a new world of personalized medicine, individualized medicine. Now the new concept is precision medicine, okay? So now it's very difficult to fund a study with a random application of something to prove that it's better with the random application of other things. Now you have to compare the standard of care, or what is considered standard of care, with the individualized care of something. Always, from now on. Because the physiology is different in everyone. Lung mechanics is different in everyone. The injury is different in everyone. Because we invent a word that is called ARDS, or an acronym, acute respiratory distress syndrome, that is not a disease. That has a diffuse damage, and the damage has a different severity. And the person who has damage has a different severity too. In fact, some of these patients will never survive because they have cancer, terminal cancer, they have a head trauma, brain death, I don't know. They have ARDS as well, but they have other diseases. So, to tell you something is, you should know, in the planet, in the world, since the ARDS net, this is the most common way to apply PEEP. The FiO2 PEEP table. You have the low PEEP table that it was applied in the year 2000, and published in the year 2000, and the high PEEP table that was published in a paper done by ARDSnet in 2004. I know how this table was done. I know. Because I was one of the guys who were interviewed. Because this is how this table were done. Without physiological basis at all. Just that was a question to 100, 200 people. They were known by the guys for the ARDSnet. And they say, hey, Jesus, if you have a patient with 70% on oxygen, an ARDS patient, how much PEEP? That was a question in the 1990s, many years ago. more than 20 years ago. And we have different ideas in those years. In fact, we have a different knowledge in those years. I will say, okay, maybe I put 12, 14, depend in what religion you are in, because there are people who believe in PEEP, people who don't believe in PEEP, like a religion. So depend on that, they got this. They create this table. And now this table is followed by everyone. I said, it's the most common way to apply PEEP today. Well, I shouldn't recommend this today. Maybe to start with, the screening, the patient arrived. The expert said that. Now, the problem with the expert is, depending if you are in the low PEEP expert group or the high PEEP expert group, because for the same FiO2, you have different degrees, different levels of PEEP. You can go, look at this, 70% go from 10 to 14. That makes a big difference. 10 to 14 is not the same. But here, it's 20. Here, the guy say, no, I put 20. Now, because the guy said 20, I have to follow 20. God said 20. And this is how is randomly applied today, PEEP. Now, what I should do? I think this will be my third or fourth message today. I think it's two ways, acceptable ways, personalized ways, precision ways to apply PEEP to every single patient, because I don't want to have, if I have tomorrow ARDS, I don't want to be treated like somebody on the table. I want to be treated according to my physiology, to my injury, to my lung scan or lung x-ray, chest x-ray, according to my blood gases, to my mechanics, according to many other things, but not to the table. Not to the table. Even though I should remember that higher PEEP is better than lower, that higher PEEP saves life. But if I apply high PEEP in patients who do not require high PEEP, I will end up doing the same thing, ventilator-induced lung injury. So, pure physiology, the transpulmonary pressure by the end expiration, end expiratory transpulmonary pressure. Instead of plateau, now it's PEEP. Pleural pressure, we cannot measure because it has to be invasive, but we have the esophageal pressure. So we know by physiology that now we have a transpulmonary pressure around 1 or 2. Even some people 0, but not less than 0. Because you have less than 0, you will be collapsed. You will have atelectasis. So and nature don't allow you to have atelectasis normally. So you say pleural pressure, normal breathing, -1. So minus is 1. However, in patients that are ventilated and now it's positive pressure, if you have a negative transpulmonary pressure, you are for sure collapsed because it's by a normal physiology. So it's just a difference, okay? You have a negative pressure, so your alveoli cannot be open, it should be closed. And this is what happened. Look at this. A patient with PEEP, because it's in the ICU that people believe in PEEP5. Yes, I have to say believe because it's becoming like a religion and serious. It's sad, it's very sad. But they say, oh, PEEP5, with the PO2 is fine. Because, the SAT is fine. I know the patient is with FiO2 of 0.5 or 0.6, but the patient has ARDS. What do you expect? But PO2 is fine. PEEP5. But if you measure, that guy, you say, listen, can you please allow me to measure the esophageal pressure? And suddenly, it's 8. So 5 minus 8, -3. Say, okay, you continue treating the patient like this way, and you will see that tomorrow you are going to be complicated because you are going to require more and more oxygen, and maybe more and more pressure will develop, and the patient is going to be worse because it's going to develop atelectasis. However, if you say, I don't belong to any club of PEEP, but just by this example, I want to increase to 10 of PEEP. You increase to 10 of PEEP, and suddenly you are positive. 10 minus 8, 2. My God. So at least, the injury is there, the disease process is there, but at least you follow physiology in this particular patient. It could be 8, could be 9, could be 11, who cares, depending on the esophageal pressure. You don't need to have more than 2. And that is the strategy that now is being followed by many people. And I want to show you just an example in a stream, okay? To show you that the limit of PEEP, in fact, PEEP has no limit, according to what I just tell you. This is a real case. This is a patient who has a morbid obesity. This is a patient who has 1 kilo per centimeter of height. It's a lot. 1 kilo per centimeter of height. He's very obese. And this patient, because he's a man, doesn't have ARDS. But he had acute hypoxemic respiratory failure. He's very obese. He has a big abdomen and a lot of weight here in the chest. A lot. And he's in a unit with PEEP 11. Because PEEP 11 provides a good oxygenation according to physician. PEEP 11 is fine. I know the patient has atelectasis, the patient is bad, the patient has sepsis, whatever. 11. But a guy comes and put a esophageal catheter, increase PEEP because he knows that this chest, cannot be ventilated with 11 of PEEP. And he realized the following. Just look this part. The PEEP is 22. Oh, sorry. The PEEP is 22. But the esophageal pressure is 26. So, again, very simple. 22 minus 26. Coming from the Canary Islands is very dangerous. But let me say, I don't talk against anybody. I don't I don't mention any name. I just give you examples. So 22 minus 26 minus 4. So no wonder why this patient will never get out of the ventilator. Will be atelectatic. Even if you extubate the patient, you are going to reintubate it very soon. And in fact, they will die. By doing those things, you will die. So what you do just is increase PEEP. I know, but it's only for this. I told you, it's an extreme. It's a patient that requires 27 of PEEP in order to be only 1 centimeter above esophageal pressure. For how long? I don't know. Maybe for 6 hours, for 8 hours. I don't know. It's something I will check every time, continuously, online. And we'll have 1. If I increase to 27, I will have 27 minus 1, minus 26, 1. That's it. Alveoli open. No collapse. Forget about the number. It's 26. I said it's because an extreme. Because that tells you something. There are more obese patients now in critical care unit, not only in the United States, everywhere on the planet, okay? It's an epidemic. And we have to realize that we cannot apply this concept of, I believe in PEEP, put PEEP to everyone. What does it mean that? It doesn't mean anything. PEEP 10, I had to put the PEEP that I require. There are people who say 5 or 15. Forget it. Why 5? It's a whole range between 5 and 15. It was a time with the nitric oxide in France, that make a lot of impact in Europe, because certain groups of French people with a lot of experience in nitric oxide, they decide that if the patient do not respond to PEEP of 10, you nitric oxide. My God, it's iatrogenic. How come? I mean, the patient requires more PEEP. No, nitric oxide. And now you know that nitric oxide is not a standard treatment. It's not recommended treatment. It's a wonderful drug, but for the wrong disease. This is the strategy that Telmore, another guy from Boston, did it to see if by applying PEEP according to transpulmonary pressure was better than applying PEEP according to the PEEP and FiO2 ratio table. The PEEP and the FiO2 ratio, table. And they found that when they have already, so the study was powered for 200 and something patients. So they stopped the study when they include 61 patients. They stopped the study because they found that the primary outcome, that was oxygenation, was already obtained after 61 patients. Was a big difference between the oxygenation measured by PF ratio. When they finished the study and calculated mortality rate, the hospital mortality rate, they found, 28, they found that was very low. The patients ventilated according to transpulmonary pressure. Not only they have less ventilator-induced lung injury, but the mortality rate was very low. So after this study, they designed a large randomized control trial that I know already that have been finished. I think they are in the process of publication. And what I heard, rumors, if the study is positive, in almost every single parameter, including mortality. This is what I heard, but I want to see when it's published. So it's PEEP, individualized PEEP. Every single patient has a different PEEP, according to this formula. The other way to apply PEEP is, well, I have to say, in the Stalmore study, before doing the transpulmonary pressure approach, they have to recruit the lung. But they did it for everyone, not only for the patient in that arm, but they did it for the patients in the ARDS net arm too. So you recruit the lung, so everyone is in the same condition at the start of the study, and then after recruiting the lung, you randomize. But here, this is a second option. But it's only two options. I don't want to give you more options. That is using what we know about the pressure volume curve of the respiratory system, use the expiratory limb. It's doing a recruitment maneuver until total lung capacity, and then decrease PEEP until you find the best compliance and the best oxygenation. And this is something I'm being described in animal. This is the only animal slide that I have in my lecture. So you do a decremental PEEP trial until you get the point in which the compliance is decreasing, and that is coincidental with the time at the oxygenation decrease as well. So we did it using this approach. We did in a study, we published in a study last year, the beginning of last year, on 200 patients. It was a pilot study. They have not the power to see difference in mortality, but you see the patient were completely different. Not only they have a better oxygenation, but better survival, even though, because it's only 100 patients in each arm, they have not the power to get a statistical significance. Now, I tell you something important about physicians who were involved in this study. The way in Spain, they treat patients, all their patients, using this. They became addicted to recruitment maneuver and decremental PEEP. In fact, since they became addicted to this, they never have used prone position in any single patient. Never. They recruit the lung and they apply the PEEP, that is required in each particular patient. The only thing they have done is in some patients, very few, less than 5%, patients who don't recover, they have sent it to ECMO. But this is the only thing they have done. Most patient responds to this. Amazing, eh? Now, there's a guy from Boston, Piron, well, he's from Italy, but he was in Boston as a fellow. He did an interesting study. He compared the ARDS net, the transmural pressure approach, and the recruitment maneuver with decremental PEEP. And they found that the last two, were equivalent, similar. They get the same level of PEEP, for patients with ARDS, the same oxygenation that was much higher than those patients who were treated with the ARDS net approach. So if you have any preference, I will tell you I don't have any preference. So the approach by Talmor with the transpulmonary pressure, or the approach by Kaczmarek and Amato and others with the recruitment maneuver and decremental PEEP, you end up with the same level of PEEP in each particular patient. Exactly the same. In this study, mean value was 21. I'm talking about moderate and severe ARDS. Compared to the mean value in the ARDS net, that was 11. This is not a study powered to see mortality outcome, just a physiological study to prove that these techniques are different, but these two are the same, similar. So it depends. You are comfortable having esophageal catheter? Fine. You are comfortable doing recruitment maneuver decremental PEEP? That's fine. We are going to the last, not to the, but I want to be before the last. A new concept, driving pressure. What can I tell you about driving pressure? Well, the message for you, to make it simple, is this is a calculation. So if the ventilator gives you a driving pressure, it's because to calculate plateau and subtract PEEP. So here in this equation, you have the two things that we are talking about, plateau and PEEP. So Amato decided to study all the randomized control trials have been published so far and put the apple and oranges and bananas together and see what happened. But I have to warn you something. First, there are apple, oranges, and bananas, of course. Second, patients were ventilated with different tidal volumes in all these randomized control trials, from 4 to even 15 or 16 ml per kilo, with different level of PEEP, with different definition of ARDS, with a lot of exclusion criteria. In fact, they only analyzed less than 20% of patients who in those centers met ARDS criteria. So more than 80% are excluded. They only include less than 20. So really, any message that you get, forget the other part that is more important. No, the more than 80% is not consecutive patients. Okay, and this is what they get. They get the following. The message is: if you have a driving pressure that is stable, mortality doesn't change. If the driving pressure increase, mortality increase. If the driving pressure decrease, mortality decrease. Essentially, is that. Decrease at what? At what level? Well, before to say that, I have to say, I already said that. That is different tidal volumes and different PEEP, but something else. They analyze data at different time points. And this is terrible, because they mix all the patients, and they said, we are going to analyze the data, only the data, this is only the data, from the day after randomization. The first day after randomization. Well, I end up by reading, I criticized, and I wrote a commentary to that paper, that the first day of randomization for this was not the same for all patients. In some studies, the first day was the same day of diagnosis, but the first day of randomization in other patients were the fourth day, 96 hours later. So how can you combine data from the first, the second, the third, and the fourth day of ARDS and say that it's taking a standardized? It's no standard. From 0 to 4 is no standard data. Because the standard data in randomization is if every single patient were randomized at the same time. But it's not. So this is very important. The other important issue here, because this is the final figure of that study, is the following. Look at this. They found, when they analyzed 1,100 patients they have, with complete data of Plateau and PEEP in order to calculate the driving. See, this is something else. From the 9 randomized controlled trial, only half have complete data. They found the following, that was a certain amount, 15, I say here 15, 14, 15, 16, maybe 15. Below 15, mortality rate was lower than the overall mortality. This one is the overall mortality rate of the population. So everything below 1 has a lower mortality rate. This is plateau pressure. Sorry, this is driving pressure. And the driving, I said, is the difference between plateau minus PEEP. And then those who has higher than 15 has a higher mortality. But you have to see this curve in a different way. Look here. This is not only the driving pressure. They analyze these patients depending on the tidal volume. Here, these guys, these patients were ventilated with tidal volume between 6 and 7.5. A mean value of 6. This one, this was a mistake. Here, it was published in New England. It's a mistake. It's 7.1. It's 7.1. You cannot have 6.1 between 5.8 to 9.2. I mean, by simple calculation. So what happened is this guy was up to 9. And look at this. From almost 6 to more than 12, because this patient has even 15 ml per kilo. Now, if you consider on the patient ventilated with lung protective ventilation with a tidal volume 8 or less, you will never get that. Or even if you get it, it's difficult to find a relationship between higher tidal volume with higher driving pressure. So what is the difference? How can you explain that? So we did a study, because I didn't believe this data. So we did a study, a multi-center study, consecutive patients, not the 20% or less than, consecutive ARDS patients, moderate and ARDS, and severe ARDS patients. All of them was mandatory that all of them should be ventilated with 8 or less milliliters per kilo of tidal volume. Was mandatory to evaluate this patient at 24 hours exactly in all these patients, 24 hours after diagnosis. And we have 600 patients, and this is what we found. We found that, yes, you know, it's a range of plateau from 15 or 16 to 28 that the mortality is below. Something that I already told you almost in the first slide. If you have a plateau pressure below 29, so, and the driving should be below, because driving is plateau minus PEEP, you know, the mortality rate doesn't change. It's almost the same. Here, 29, by serendipity, 29 has the same mortality rate as the overall cohort. And after that was an exponential increase of mortality. This is plateau. Let's see what happened with driving. So we calculated driving, and we found the same thing. But no 14, no 15. We found that should be above 18. Until 18, you are fine. I think this is because, first of all, tidal volume is low, and second, the PEEP levels now are higher than in the past. I think there will be a time that recording the past, like all these meta-analysis based on the studies published 25 years ago, they have to have an expiry date. You don't think so? It's a moment that you have to stop using data, those data, to send new messages to us that are not valid anymore. because the patient we are treating in a different way than today. I think the past has an expiry date. You don't think so? Yes, we are. And the last concept is mechanical power. This is another invention. Forget about this formula. It's just that Gattinoni used a number of patients of ARDS and normal guys to unify. The concept is brilliant. To unify, the concept is brilliant is because to unify all the parameters that are involved in ventilating during lung injury and to see if they can unify in one single concept, in one single parameter, it's called mechanical power. That is the equation of motion applied to the lung, to the ventilator. And he found that this complicated formula, as you see here, because this is an engineer concept, okay, mechanical power. So by applying and substituting in the engineer formula the values for respiratory parameters, they found that the mechanical power, the energy transfer from the ventilator to the patient, or the ventilator-induced lung injury, increased exponentially with any increase of tidal volume, flow, and driving pressure. But here, driving pressure, you have to interpret it as an increase in plateau pressure. And only increase linearly and very little with PEEP. So, tidal volume, again, plateau, is more important for ventilator than PEEP. And now this is my final slide, how I can summarize what I said today. Now, in the new world of precision medicine, individualized medicine, I would say that because now the new concept the fashion is the driving, keep the driving below 18, the lower is better. Keep the plateau below 29, below is better. Even if you have a plateau less than 25, you can increase tidal volume up to 8, because we said that up to 8 will be fine in order to maintain the PCO2. In patients with ARDS, I think you can use two ways to set the PEEP. One is the best compliance, as I said, after a recruitment, and the other one is the positive transpulmonary pressure. We know by experience that patients with moderate and severe require levels of PEEP from 12 to 20 because it's above the closing pressure. And in mild ARDS, very mild ARDS, the PEEP is between 8 and 15 because it's close to or even above to the closing pressure in those patients. You see, it's not the same. And then in normal lung, even anesthesiologists today, for a simple appendicitis, they are applying a minimal level of 5 of PEEP to avoid atelectasis in the postoperative period. And that's it. Thank you very much.